you, but I tested out this morning and it wasn't really working. It was kind of fuzzy.
Okay.
So we're going to use this, and I'm just going to hold it out to you. It picks up really well, so it should be fine.
Okay.
So to begin, if you could tell me your first and last name and spell it for me.
Sure. My name is Dawn Delgado, Dawndegado.
And what would you like your title to be?
Marriage and family therapist and certified eating disorder specialist.
Okay, great. So just tell me, I'm going to start off just speaking kind of generally. Tell me generally about eating disorders. Tell me what causes, I mean, obviously there's many causes.
Yeah.
But tell me generally, like, just a really broad kind of answer.
Yeah.
We're kind of just, like, narrowing down the questions
Okay, cool.
about eating disorders.
Cool. So eating disorders are a complex and challenging disorder to understand. And when we're talking about root causes, we in the field use what's called a biopsychosocial spiritual approach to understanding them. So we're looking at biology, genetics. We're looking at biochemical reactions that are happening in the brain. We're looking at social factors, including the family, relationship disturbances, the whole realm of relationships and family issues, as well as, other social factors. I know we're going to talk about the media and, societal pressures that we have here. We're filming in Beverly Hills, as well as spiritual, which sometimes is left out but is very important, how an individual, the lens that they see their spiritual world through, so religious or otherwise, how they see the world. So sometimes there's a disruption in one of those areas or multiple areas. And that's really, under that context, we can start to look at the root cause of an eating disorder and where it's really coming from.
Do you feel like one of these aspects is kind of more common than the other? Do you see it more often?
It's a really good question. I would say it's a mixture of all of these factors. And there's a saying that we use in this field that is, genetics loads the gun and circumstances pulls the trigger. So often a person will have like an underlying depression or anxiety disorder, maybe substance abuse tendencies in their family. They also might have the genetic loading for an eating disorder from, one or both parents. And then there's kind of the perfect storm of situations that actually pulls the trigger for that individual developing it. So it might be anything from, we talk about trauma with a capital T, different types of abuse, sexual, physical, emotional abuse, spiritual abuse, and then there's trauma with a little t, and that is just as detrimental. That could be something for someone like moving. It could be any type of life transition. Bullying is a big one that I'm seeing a lot in my private practice. Even a comment from a coach or a teacher. These are all the circumstances that can combine with that genetic loading to see an eruption of the eating disorder.
Okay. And how does it usually begin? Like, how can you kind of pinpoint the beginning stages of an eating disorder?
Another good question. I think the longer that you work in the field, the harder it is to narrow those questions down because you've seen so many different types. But for some individuals, there's a sudden onset. So it could be one comment or one, detrimental event at school or one family situation or one incidence of abuse that happens. And then it's like a conscious sometimes decision to act out on the behaviors. For other individuals, it's kind of creeping along with time. They may be self-medicating for one of these underlying mood disorders, and it may just start to compound. Oftentimes individuals, when they start eating disorder behaviors, they may get positive reinforcement from their families or communities, people just with all of the best intentions saying, hey, you look great, what's going on? You lost that extra 5 pounds, that's wonderful. Little comments that seemingly, are not that harmful that turn out to be extremely detrimental to that individual. And then the ball keeps rolling. So that would be kind of a more gradual onset eating disorder.
Okay. And as a therapist, how can you, when you see someone, can you can you distinguish if they are just naturally thin or if they have an eating disorder? And if you can, what are their habits that kind of distinguish them?
Good question. What I like to remind people just on the education point is that eating disorders show up in all shapes and sizes. With the addition of binge eating disorder into the DSM-5, we are treating, not only anorexia, bulimia, we're also treating binge eating disorder individuals. So body size is not necessarily correlated with the amount that someone's struggling. So in our eating disorder individuals who are underweight, sometimes you can tell when you've been in the field for a while, more because there's kind of a look on their face. You can distinguish behaviors at a table or at a restaurant that are indicative of the possibility of an eating disorder. But I do kind of want to steer it away from just weight, because you never know if someone is struggling with something medically or if there are other contributing factors or reason why their weight is either above or below a normal BMI. So some things you might notice at a table or at a restaurant with an individual who is struggling with an eating disorder. You might see what we call microbiting, taking little teeny tiny bites, cutting things into little teeny tiny pieces. On the restrictive end, we often see individuals and redirect them away from pushing food around on their plate. Sometimes when malnutrition combines in with eating disorder behaviors, you start to see OCD-like symptoms. So you'll see different rituals, different types of fears, maybe avoidance of one certain type or color of food. So those are kind of in the restrictive arena. On the binge eating disorder or binging and purging arena, you may see individuals eating extremely rapidly with kind of a zoned out look on their face. You may see individuals who frequently use the restroom immediately after or during a meal. So those are all kind of warning signs if it's a loved one that you may want to inquire if they need support.
I'm so happy that you mentioned about the binge eating. Every other therapist I've asked, I kind of asked the question specifically to get that answer, and no one has mentioned it. So when you said it, I was like, oh my gosh, thank goodness.
Oh.
Thank you.
Yeah.
Okay, last
If I can interject for just
yeah.
a second,
Yeah.
I think it's really important that when we're educating about eating disorders, it is really important to throw in all different types, because when people focus on the eating disorders that are more visible, it can be really isolating and almost ostracizing to people who are of average or above average weight, who are struggling just as much. And people, unfortunately, the mortality rates, for eating disorders, very sad. People do struggle and do die at every different body weight. So, extreme obesity and an undiagnosed binge eating disorder, or someone of average or above average weight who's struggling with bulimia, can be just as sick and just as medically compromised inside. So,
is there one specific type that's more common than the others? Like anorexia, bulimia, binge eating?
I don't have a statistic for you on that.
Okay, no, that's fine. Is there one that, as far as your patients go, you don't have to answer this if you don't want to. But as far as your patients, is there one that you've seen over time that's more common?
I see a mixture of, anorexia and bulimia, and even eating disorders that bleed into one another. So as an individual, for example, goes through a course of treatment, they may start out with one eating disorder, and as they're learning how to self-regulate their eating behaviors, I've seen eating disorders, kind of morph into another type or another presentation of an eating disorder. So I've seen individuals go from diagnosis of anorexia to bulimia, potentially to binge eating disorder, if they're not really getting into those underlying roots and really, treating those underlying pieces. In terms of what I see in my practice, I would say it's pretty even mix of anorexia and bulimia. I have worked with binge eating disorder clients more in a treatment setting. I think with insurance authorizations, sometimes they're not accessing treatment as readily as other forms of help, or with the increased hype in some bariatric surgery and quick weight loss fixes. I think oftentimes our binge eating disorder clients are, unfortunately seeking out the help of weight loss clinics and kind of the med spa type treatments that aren't actually targeting the underlying issues that cause the eating disorder to start in the first
Right.
place.
And this is just my own curiosity. Is it usually when they kind of, I guess, transition from one eating disorder to another, kind of bleed into each other? Is it usually anorexia to bulimia, would you say, or not necessarily?
I again don't have a statistic on that. From my experience, I have seen it move in that direction. If again it's not adequately treated, or a client doesn't get the adequate length of stay in a treatment program, I have seen it move in that direction. I'm trying to think if I've seen it move in the other direction, and I'm sure it has happened. But from my perspective, it does tend to go from the more restrictive disorders to trying to learn how to self-regulate with food, or even moving from a restricting anorexia to the restriction binge cycle. So from restriction to restriction binge to restriction binge and purge, possibly with different methods of purging. So in my experience, that's what I've seen as kind of the progression in that direction.
Interesting. Okay.
As well as, let me just add, with the binge eating disorder, often there's dieting and binging cycle as well. So I've seen it go from someone who is maybe overweight or even obese to can present very similarly to an anorexic in terms of behaviors.
Okay. Interesting. Yeah, no, that totally makes sense. I'm just going to readjust this real quick. Okay, so as a therapist, this is not going in the video, actually, I'm just wondering, do you
Okay.
refer patients to treatment centers, or do you just kind of handle, like, tell me a little bit about, I know you don't want to talk about your, like, the practice, but tell me a little bit about how you go about, like, handling your patients, and this is, like, not for the video at all.
Sure,
Yeah.
absolutely. I think it's a really good question. All levels of treatment, from acute inpatient to residential treatment to partial hospitalization to intensive outpatient to outpatient, which would be my private practice. We follow the APA, American Psychological Association, guidelines for levels of care, and it's very important that individuals are up to date on what are those cutoff criteria for when it's ethically appropriate to treat a client in a particular level of care. So I am quick to refer if a client in my private practice reaches a point where their acuity and their symptoms reach a level where once, maybe twice a week with individual therapy is not enough. And I feel very strongly about practitioners referring in at that point instead of getting to the place where they're trying to treat it maybe 3 times a week, or if it's requiring 2 dietary sessions and 3 therapy sessions a week, that's no longer appropriate for outpatient care. They definitely need to be assessed for an intensive outpatient program where they have community support, meal supervision, and psychiatric monitoring if necessary, and more frequent labs and medical monitoring. So I think it's really important that those kind of categories that are set by the APA are followed, and it's actually pretty risky for practitioners to treat clients in an outpatient setting if they're at a higher acuity level than that person can handle on their own.
Okay, interesting. Yeah, I didn't know
Is
exactly.
that helpful?
Yeah, no, that's very helpful.
Yeah.
Yeah, I was just kind of curious myself. Okay, well, as a therapist, what steps do you take to try to kind of like figure out what's going on and help the patient recover?
Absolutely. I always start with the biopsychosocial spiritual assessment to get a full understanding of all different areas of what's happening with that individual. I think it's extremely important because there's no 2 cookie cutter eating disorders. There's no 2 cookie cutter individuals. So really understanding and using that the first couple of sessions to get a really good understanding of what is happening with that individual. I like to start with a beginner's mind, pretending that I don't know a thing about eating disorders, and really try to hone in and understand that individual. It's, all too often we can kind of categorize it into, oh, I've seen anorexia before, I've seen bulimia, I've seen binge eating before, and we can overlook the person who's sitting right in front of us. So I start with that complete assessment, and the other piece is developing that rapport. So attachment is something that's, attachment theory and attachment practices in therapy is something that's very important, and especially for eating disorder clients, that relationship becomes a really core piece of the work. That there's so much secrecy and shame in seeking help for eating disorder behaviors, oftentimes, that it takes a really strong relationship to be able to help that person feel safe and comfortable to share what's happening with them and share the thing that they've hidden and probably kept secret for a long time before they come to you.
And what about once they're kind of done with therapy, that attachment is broken? Do you think, how does that affect the patient?
And that's another really good question. I'm glad you asked, because that's another area that I feel is extremely important. We probably don't get enough training on that in our psychology training, and even in our eating disorder training, that it's important that process is gradual and smooth. It's important that we work through our own issues of countertransference as therapists. We're people too, and that we understand the role that attachment is playing in the therapeutic relationship. So it's important that that is gradual, and that we are finding that balance of helping the client to feel comfortable and safe with us. And also, I always think of it as a gentle nudge out the door, that we don't want to foster dependency, and we don't want to replace eating disorder symptoms with a foster dependency on a therapist or a treatment team. So I always think of it as, initially establishing that rapport and relationship, and then I'm pretty confrontational, gently confrontational, I call it, with my clients, and I give them that gentle nudge out into the world to both face exposure to the things that they're avoiding, to face the social and the family situations that were part of the initial disruption, and to gently start to nudge them to become their own internal therapist and dietitian. That's really the goal. Our job is to work ourselves out of a job. Our job is not to try to keep someone in a therapeutic setting for 10 or 20 years.
That must be really difficult.
It's an art. I love it.
Yeah?
Yeah.
I'm just thinking, I told you I had an eating disorder, so I'm just thinking about when I had my therapist and we just kind of, I guess, stopped. I remember it was like, I felt like I had a loss or something.
Yeah.
Like I felt so detached. I mean, we were detached. I felt so lost. I don't know.
Yeah.
So I'm just thinking, I don't know, how do therapists kind of slowly, and you said it's a gradual process. I'm not sure mine was a gradual process, but
yeah,
that's really interesting that you said that. That's really interesting to know.
Yeah.
So, yeah.
And hopefully by that point, when you're ready to step down or to terminate therapy, hopefully that individual has the confidence and the tools to be able to feel the feelings of grief and to experience that loss and process that loss, and talk and cry and work through it, and not replace it with symptoms or eating disorder behavior. So hopefully by that stage, that's kind of the next challenge, is doing it on your own, maybe with the support group.
Right. And yeah, I think therapists know what they're doing, so they know what stage they're at, and they know what stage they can kind of push them away. Interesting. Cool. Okay. Well, so now, have you always been a therapist here in Los Angeles, or have you worked elsewhere?
My graduate training and my intern years and my therapist years have been largely in Los Angeles. I got my early experience at the Center for Discovery while I was still in graduate school, and I became licensed in 2007 and went on to work in this field, in the treatment field, in a variety of capacities. Starting my private practice in 2007. I've been doing that ever since. And then I did have the opportunity to move and work overseas. So
it.
that was, yeah.
Was Indonesia one of them?
Indonesia,
Right.
yeah.
Okay.
I started a practice in Bali, and was able to really expand myself and my expertise because I saw multicultural and a variety of diverse issues. A lot of eating disorders, which was interesting to have the comparison between eating disorders in the community, you know, of Los Angeles, and also to see the variety of eating disorders and the presentation from the expatriate community, from multicultural individuals, and people living overseas. They kind of present in an interesting and different way. So I got to do a private practice and a group practice there with some amazing practitioners from all over the world. And also was because there's a lack of resources for clinicians on small islands like Bali and like Indonesia. So there aren't the same type of residential and partial hospitalization structured systems that we have here. So I was flown over to a couple of nearby areas, Java, another island, Singapore, to work with like hospitals and private families to support them in their journey.
That's
so
great.
that was really
Oh my
exciting.
gosh, yeah, that's so exciting.
Yeah.
I love traveling. Okay, well then, so you've had experience kind of all around. So, how do you think that people living in LA are really affected, especially because it's LA media center? How do you think that people are really? How do you think the media affects people and kind of causes them to develop an eating disorder in LA, kind of compared to other locations?
To other places, that's
Yeah.
a really good question. We're here in Beverly Hills, you know, right in
Especially
the
Beverly Hills,
capital.
yeah.
There's a modeling agency right out the window that we see their swimsuit shoots, and yeah, it's a really interesting community to live in, especially when you're looking through the lens of, you know, the therapeutic lens of these contributing factors that help to form eating disorders. I think there's societal pressures, you know, anywhere you go in the world, particularly in a city like Los Angeles, there's probably an increase in the influence that the media has on individuals. On my right here, I was noticing all the big, huge billboards that are now advertising the freeze your fat and different kinds of, you know, insane messages that are just continuously bombarding people here. I think it's important in the eating disorder field to work with individuals on conscious viewing of the media and conscious protection from the media. You know, we get inoculated from, sorry, I'm losing the word.
Oh, you're fine.
We get vaccinated, so let's start again.
You're fine.
We get vaccinated against, you know, a number of different diseases that could infiltrate our bodies. And I think it's also important to think of media viewing in that way, that we need to develop the tools to protect ourselves from all of these messages that are bombarding us. So from advertisement to, you know, conscious television viewing, if that's something that individuals do, to even conscious news viewing, especially in Los Angeles. There's a blur between news and you know, high fashion and celebrity influence. So it takes a conscious effort to not go with the flow of the media and to view things through a conscious standpoint.
Okay.
Does that answer your
question?
question?
Yeah, no, completely. Yeah, no, it really does. Actually, that was a very thorough answer. Cool. Okay, so media was kind of like outside factors, was kind of one of the aspects that influence an eating disorder. You also mentioned spiritual.
Mm-hmm.
And could you speak more about that? Because I don't know much
Yeah.
about like this kind of aspect.
Absolutely. That's an area that's really important to me in my work with clients. It often comes later in the stages of recovery, but I do feel it's very important for individuals to develop some kind of, and I don't care what it is, but some kind of spiritual framework to see the world through. Something that helps them to understand that there's a power greater than themselves. While I'm not a 12-step therapist, there is a step in the 12 steps about, you know, seeing yourself as part of something larger. And I think that's important to remember, because the eating disorder has kind of a narrowing perspective, even blinders, if you want to think of it that way, that the individual gets extremely focused on their own body, their own weight, the numbers on the scale, calories, the labels, and it's sort of a self-protective mechanism to kind of narrow in on something that is controllable, that is, contained, that is labeled and safe when the world gets overwhelming. Our eating disorder clientele are extremely sensitive and extremely intuitive people, and it can get pretty overwhelming out there. So I feel it's extremely important for individuals for us to help them find their center, and find their center in themselves, in their family system, in their community, in their world, and then in their universe, whatever that is. Something that helps them to hang tight and to stay centered when things get extremely overwhelming and chaotic.
Let's see. Okay, so that's kind of like I feel like people, even if you're not going through an eating disorder, if you just went to a therapist, it's something that they kind of train you also to do. So that's great that you kind of combine that with like eating disorder therapy, if that just made sense. Okay, this is kind of, this question's kind of off the topic of like where we're going, but I was just curious, do you have patients that come in and talk to you, but, and you don't have to answer this if you don't want to, but that kind of, because they're hiding it, they kind of, it's almost like playing a game, so their responses are like kind of like as if they're kind of trying to trick you, but you know what's going on completely? Like,
Yeah,
okay.
yes, that's a good question. And commonly in my practice, both in treatment centers and also in private practice, people come in with a variety of different self-protective and kind of defense mechanisms. Maybe they're not comfortable, maybe they're lying, maybe it hasn't been safe in the past for them to tell the truth, maybe there's a little bit of an attention seeking with playing some kind of game, and that's something also with years of experience in the field, you kind of develop that fine-tuned sense. It is a very intuitive practice. While we're trained, it is very intuitive, and you have to often listen to that voice inside that says that doesn't feel like the truth, or when you lie to me, your eyes kind of look up into the corner, or and so it's working with that individual to help them identify what they're doing, why they're doing it, because there's a reason for it, and to find a different way that's more functional, more adaptive for them to communicate, not only with you, but with, again, their families, their friends, and the world around them. So I see those as defensive mechanisms and an individual's attempt to get their needs met, whether it's attention or whether it's a safety issue or whatever the root is.
Or even like if they just don't want treatment, they're very reluctant. So
that's a good point. Oftentimes, especially with adolescents, they feel that they're being forced into treatment. Oftentimes parents have set consequences that if you don't go to treatment, if you don't see this therapist, you're not going to get your allowance, or I'm not going to let you participate in sports. So oftentimes they don't really want to be there, and that's also where therapy is an art, because it's your job to help engage them and to help them feel safe and to help get them talking and processing in whatever way that is. And it might be through words, and it might be through movement, it might be through art, it might be through videos. I use the tools often. I bring in my iPad into session and show little videos to provoke a reaction, or show little inspirational snippets, especially if a client is more nonverbal and needs some help kind of opening up. So it's really your job as a therapist to figure out how to get them to feel safe and to open up and communicate honestly and directly.
Okay, it's interesting hearing it from a therapist's perspective. Okay, so going into this news aspect that I have to cover. So it's been said that October through January, the months of October through January it's considered eating disorder season, because we have all these holidays back to back, and they kind of all revolve around food and getting together over a meal or something like that. So, can you just speak to this? Like, what are your thoughts on
Sure.
this? What people term eating disorder season?
Sure. Well, I was joking with you before, when you work in eating disorder treatment, every season is eating disorder season, whether it's the summer and swimsuit season, or the fall and winter and holiday season, or spring and, spaghetti strap dresses. So every season is eating disorder season from, my perspective. But it is true that from, Halloween till New Year's, there's a lot of holidays that are potentially triggering to individuals with eating disorders in a number of ways. I would start again with the underlying issues, and that these are typically holidays and times and a season where it's about family. It's about celebrating being grateful. It's about, giving thanks to the people who've supported you through. So oftentimes, individuals, maybe they aren't in a great place. Maybe their relationships with their family are very disruptive. Maybe they were abusive. Maybe they aren't feeling that gratitude and joy of the holiday season. So it can further push them and, kind of trigger them into the isolation direction or into their depression or anxiety. So there's that level on like the underlying root level. And then there's also just the things that are associated in our society with those holidays. There's all of the candy on Halloween, which is a huge binge trigger often. Often individuals will need to bring in that candy and, keep it in a safe place or remove it from themselves and then integrate it back in as they feel safe. There's Thanksgiving, which is a very triggering time for most people with eating disorders. We just had our Thanksgiving community dinner here at this Beverly Hills Treatment Center and supported them through it. So there's a lot of celebration around food, and that can also be a really triggering time for eating disorder recovery individuals.
And do you find that you have either, I guess there's two questions. So, do you see that after the holidays, do you have kind of maybe more people coming in wanting to treat eating disorder? They developed one over the holiday season, or do you have, or also the patients that are already here after the holidays, is it harder? Is it almost like not restarting, but did they take a step back and you kind of have to push them forward more?
Yeah, good questions. There's definitely around the end of the year, in my experience, a surge of inquiries and calls about therapy. Maybe they're New Year's resolutions, maybe they're a result of the holiday seasons, like you're saying. So that's often a time where we do see a flux of an increase in inquiry anyway. And in my private practice around the holidays, often after those family visits, and again, I see it more in terms of the underlying issues. After those family visits, individuals will need to, come back in and process, and they often have a lot of stuff that was triggered around those situations with, maybe the family being the underlying piece, and then, well, all of that food was there, and I happened to, binge and purge and resort to old eating disorder behaviors or